Welcome, everyone, and thank you for joining us for GLP-1 medications and bone health. Before we begin, Osteoporosis Canada acknowledges the land that our offices located in Toronto are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. My name is Tracie Napoli, Director of Fund Development and Marcom at Osteoporosis Canada, and I will be your webinar host. Thank you to ThinkBeef.ca for partnering on this educational webinar. This webinar will provide general information. It is not intended as individualized health advice. If you have questions, please consult your healthcare provider. Now, during the webinar, we would love to hear from you. So if you have questions related to the topic, just click the Q&A icon at the bottom of your screen. We will do our best to answer as many questions as we can during the webinar within the time available. Osteoporosis Canada is the only national organization serving people affected by osteoporosis, working to educate, empower, and support individuals and communities on bone and muscle health and in the risk reduction and treatment of the disease. We look to the best experts to inform our care guidelines for patients, the general public, and care providers. Our Scientific Advisory Council is made up of experts from across the country in osteoporosis and bone metabolism and is a volunteer membership. Our organization provides medically accurate information to patients, healthcare providers, and the public. It is now my pleasure to introduce our webinar presenter for today, Dr. Claudia Gagnon. Dr. Gagnon is an adult endocrinologist at CHU de Québec, Université Laval, full professor in the Department of Medicine at Université Laval, and researcher at CHU de Québec, Université Laval Research Center. A large part of her clinical practice focuses on the treatment of osteoporosis, metabolic bone diseases and disorders. Her main research interests are on the impact of obesity, diabetes, and bariatric surgery on bone health. Dr. Gagnon is actively involved with the Osteoporosis Canada Scientific Advisory Council and in various provincial and national committees, including Diabetes Québec, Diabetes Canada, and INIS. She has collaborated on the international guidelines on vitamin D supplementation after bariatric surgery and X-linked hypophosphatemic rickets. Please welcome Dr. Gagnon.
Thank you, Tracie. I'm going to just share my screen now. Okay. So good afternoon, everyone. Thank you for joining the webinar today on optimizing bone and muscle health with GLP-1 drugs. So at the end of this presentation, I think you'll be able to first summarize the health benefits and the impact of GLP-1 drugs on bone and muscle health, describe strategies to mitigate bone and muscle loss while taking GLP-1 drugs. So here are my disclosures, but none are related to today's topic. So I'll start with two case scenarios. So the first one is a 65-year-old man with long-standing type 2 diabetes. The diabetes control is not at target despite being on 3 diabetes medications. Unfortunately, he has diabetes complications, namely cardiovascular disease and starting to have a bit of renal complications. So he wishes to improve diabetes control and perhaps also lose some weight. So he wants to discuss GLP-1 drugs. The second case is this time a 50-year-old woman who struggles to lose weight despite lifestyle changes. So her goal is to improve her health. She has a metabolic liver disease, which was called before fatty liver disease, and had a heart attack, unfortunately, a few years back. She also wants to improve her quality of life and be able to walk a bit more because she has pain from knee osteoarthritis. So she wants to discuss GLP-1 drugs as well. So they want to know how these medications work and what are the health benefits of these medications. So, of course, there's a place for these medications worldwide and also in Canada. These drugs, as you know, have been developed initially for the treatment of type 2 diabetes and obesity. In the latest Canadian Health Measures survey conducted in 2022-2024, it showed that 2/3 of adults and 1/3 of youth had a BMI, which is body mass index, a correction of weight for height, in the overweight or obese category. About half of the population had also abdominal obesity, so fat within the abdomen. And we know that this regional fat triggers a lot of inflammation and is strongly associated with the development of complications of obesity, such as diabetes and other cardiometabolic problems. If we compare to the pre-pandemic period, since 2019, there's been a 60% increase in the prevalence of obesity in Canada. As I said, obesity increases the risk of diabetes, but also of many other health problems. And in terms of diabetes, one person out of 10 in Canada has diabetes. So how do they work, actually, these drugs? So GLP-1 is a hormone that's secreted, a molecule that's secreted by the intestine in response to a meal. So it's naturally in your body. And once secreted, it has an effect on the pancreas to increase insulin and decrease glucagon. Insulin is a key hormone to lower blood glucose level. So how it works to actually improve diabetes control. It's one of the most effective medication that we have to actually achieve this goal. And it does that without actually inducing weight gain. It actually reduces weight and without having hypoglycemia, low blood sugar, which is very important for patients. In addition, GLP-1 will act on the brain to increase satiety and decrease appetite, and this is how it will trigger weight loss. It also acts on the stomach to decrease gastric motility and gastric emptying. So this is where some of the side effects, the most common side effects actually of this medication come from. So it may cause nausea, vomiting, sometimes constipation, diarrhea. But these side effects tend to happen early in the course of starting these medications. And they also tend to disappear in most of the patients over time. So this is a reason why we start these medications at a low dose and increase it very progressively. So now I wanted to give you an overview of the development of these drugs. So these drugs started with diabetes, for the treatment of diabetes. So the first drug was commercialized in 2005, actually more than 20 years ago. The first one was called exenatide. So I've put the generic names and also the commercial name because some people might relate more to the commercial name. So exenatide was first commercialized as a twice daily subcutaneous injection. And then in 2010, liraglutide, also called Victoza, was commercialized, and then it was a once daily subcutaneous injection. Then in 2014 and 2017 came the weekly subcutaneous injections of dulaglutide, also called Trulicity, semaglutide, or Ozempic. And in blue, it's all the GLP-1 receptor agonists. But then in 2022 came tirzepatide, which is the first commercialized dual GIP and GLP-1 receptor agonist. GIP is another molecule secreted by the intestine, which will also increase insulin secretion and act on other organs. So it increases the impact of these medications on diabetes control and weight loss. So, and when you go from left to right, there's an increase in the efficacy of these medications for diabetes, but also for weight loss. And so when these were developed as part of clinical trials, we've seen that the induced weight loss. So initially, it was about 2 to 5% on average with the older drugs. So the industry thought, well, we'll develop these drugs, we'll study them for the treatment of obesity, but at a larger dose, because we knew that the effect on weight loss was dose dependent. So then came specifically indicated for the treatment of obesity, liraglutide, now at a larger dose, and it was commercialized under the name of Saxenda, which was a daily subcutaneous injection. Then in 2021 came semaglutide, also called Wegovy, and in 2023, tirzepatide, also called Zepbound. So, and I just wanted to let you know that a lot of other medications are under development, combining GLP-1 receptor agonists with another molecule, 2 or 3 molecules, to amplify the effect on weight loss, but also reduce the side effects. So lots of other drugs that may come on the market over the next few years. When you go also from top to bottom, there's an increase in weight loss. So I wanted here to show you what's where's the place of GLP-1 drugs in the tools that we have to induce weight loss. So with lifestyle modification alone, typically in the studies, on average, it will induce a 3 to 10% weight loss. Of course, people may lose less and others more, but on average, that's what we see. At the other end of the slide, we have metabolic surgery. So depending on the type of surgery, sleeve gastrectomy, Roux-en-Y, biliopancreatic diversion. So we see between 20 and 40% weight loss, so much more weight loss. So GLP-1 drugs are in the middle. So depending on the actual drug, the dosage, it's going to be on average range from 5% to even greater than 20% with the dual receptor agonist. So it's not surprising now that almost 3 million Canadians use GLP-1 drugs because they're really effective for diabetes management and for inducing weight loss. Having said that, they're not just drugs that are really effective for diabetes and obesity, but we've discovered now that they act on many other cells and they have health benefits that go beyond that. So this is a figure that I took from a review article written by Dr. Daniel Drucker, who's a Canadian from Toronto. He's an endocrinologist and a researcher, and he was a pioneer in the development of these GLP-1 drugs more than 20 to 30 years ago. So this paper was published 2 years ago, and already it's outdated. But some of these are still true. So you have in the middle the evidence-based data that we have on the benefits. So as I said, it's the most effective drug that we have to reduce actually HbA1c, so diabetes control. Have even seen some of my patients being able to be off insulin therapy with these drugs without having, hypoglycemia, which is great. Weight loss we've discussed, but there are also cardiorenal benefits. So it's been shown both in people with type 2 diabetes and those without diabetes to reduce heart attack, so myocardial infarction, heart failure, reduce the risk of cardiovascular death and of developing or progressing of kidney disease, and reduction of stroke as well. So it reduces, and the mechanisms why it does that, it's not just due to weight loss, but also to other mechanisms. So it reduces blood pressure and inflammation. It improves lipid profile as well. What's changed is what's on the left, so the investigational. So since then, it's been shown that it's also beneficial to improve metabolic liver disease and peripheral artery disease as well. But high quality studies have shown that, so far there's no benefit on Alzheimer's disease, although there might be some benefits in some subgroups. So now that they heard, so we've discussed how it works, what are the potential health benefits of these medications, they want to know because they've heard that GLP-1 drugs may lead to muscle wasting and fractures. So they want to know, is it true? And if they're at risk of having these. Before starting on this part of my presentation, I really wanted to take a few minutes to discuss what's the muscle and bone health status of people living with type 2 diabetes and obesity, even before we start GLP-1 drugs. So in terms of muscle, some people with obesity and diabetes may have what we call sarcopenic obesity, which is a coexistence of obesity or diabetes with sarcopenia, which is low muscle mass and also reduced muscle quality. So there's fat infiltration within the muscle, which induce less muscle strength. So it puts people at a higher risk of falls, but also fractures. So there are some risk factors of having these. So if you're older, generally greater than age 65, if you lead a sedentary lifestyle, malnutrition, and we also know that people who have been weight cycling are also at greater risk. In terms of bone health, there's also bone fragility in the context of these diseases. And it's mainly, we know that generally bone mineral density is normal or even perhaps slightly greater than normal, but the problem is mostly a reduced bone quality. In diabetes, if the diabetes control, having high blood sugar for a long time will go into the bone, and in bone you have the collagen fibers that are really important for the bone, and you can have what we call that, it the glycation of the collagen fiber. So it becomes like sugary, if you want. And so it's more rigid. There's also a lower bone turnover, so lower bone remodeling and renewing in these conditions. So it increases the risk of fracture. And once again, the risk factors are very similar to what I just said. So elderly people, those with abdominal obesity, and with a longer duration of diabetes, the presence of complications of diabetes, and glycemic control that's not been on target for a long time. And also, in terms of weight loss strategies, what happens to bone? What do we know? So generally, when we lose weight, there's going to be most of the time, some kind of muscle and bone loss if there's no mitigation strategies in place. So with lifestyle medication, even with 3 to 10% weight loss, there might be a little bit of bone and muscle loss. And some studies, not all, have shown that there might be an increased risk of fractures. With metabolic surgery, and especially with malabsorptive surgeries, Roux-en-Y gastric bypass, biliopancreatic diversion, we know several studies have shown that there's an increased risk of fractures, and there is bone and muscle loss. So it would be expected in a sense that GLP-1 drugs may lead to the same thing. So we'll now summarize the literature on GLP-1 drugs and lean mass. So what's lean mass? Actually, most studies have looked at lean mass and not like just muscle mass, because the tools we have to evaluate that will look at lean mass, which is anything that's not fat within the body. So the organs, muscle, and the bone, and water as well. So I'll summarize here what the high quality, the best quality of studies we have, and we call them randomized controlled trials, or RCTs. So this study was published like in 2025, so very recently, and it grouped all the randomized controlled trials done on this topic. So it was 22 studies that included over 2,000 people with either diabetes or obesity. The mean age of all the study populations, it was quite relatively young, between the age of 35 and 60. And what they found is that it was associated, the use of GLP-1 was associated with about a 20% of total weight loss. So in other terms, 25% of what you lose is lean mass. And generally speaking, it's about half of the lean mass is muscle mass. It was seen especially with the GLP-1 drugs at the obesity dose, so at the higher dose. And unfortunately, there are not enough data so far to conclude on the impact of these drugs on muscle quality, because perhaps while you lose weight, you might reduce the fat and the inflammation within the muscle, but we don't have good data on muscle quality, muscle strength, and physical performance with these drugs. But I'm sure lots of these studies will come up in the near future. Now let's move on GLP-1 drugs and fracture risk. And I've divided these data in people with type 2 diabetes and in people with obesity, because that might be a bit different. So I summarize in 2 slides a whole lot of studies on this topic. So generally, in people with type 2 diabetes, there's either a neutral effect on fracture risk or even a reduced risk of fractures. If you're using more of the older generation of GLP-1, like the Victoza, Byetta, the older daily injections, GLP-1 at diabetes dose, so even with semaglutide like Ozempic at the diabetes dose, if you have lesser weight loss, and if you age less than 65 years. So the counterpart is that there may be an increased fracture risk in people using the dual receptor agonist tirzepatide versus GLP-1. And if you have greater weight loss. And some data have shown that if you're older than 65 years, you may be at increased risk of fracture as well. There hasn't been, to my knowledge, at least data in people with type 2 diabetes who had also osteoporosis starting these drugs. So I think this would be very interesting data to have, though. Because in people with diabetes, I think why we're seeing that is that I think high sugar level is a risk factor for a reduced bone quality in this population. So you might actually improve bone quality by using these drugs if you're not losing a lot of weight. Because then if you lose a large amount of weight, you're going to also perhaps reduce your bone mass as well, especially if you already have a lower bone mass and you have osteoporosis. But I'll discuss later the mitigation strategies, though, that are really interesting to optimize your bone and muscle health if you're starting that. Now, if you look at GLP-1 drugs and fracture risk now in people with obesity without diabetes, I must say there are very limited data in this population. We, however, have some data in older people at higher risk of fracture. So with either osteoporosis, osteopenia, or already had a fracture, or taking either semaglutide or tirzepatide. So there was a higher bone loss at the hip if weight loss was larger, and among these in people without diabetes. So we certainly need more data. So now I want to come back to the two case scenarios that I presented. So I've put in red the risk factors for sarcopenia and bone fragility in these patients, because they ask me, am I at risk of having muscle wasting and bone fragility? So in this first case scenario, this person is age 65, so just the limit of, we might think might be a risk factor. Long duration of type 2 diabetes, diabetes control not at target, and the presence of diabetes complications we know are already risk factors for bone fragility among people with diabetes. So this person already has risk factors for sarcopenia and bone fragility. So we discuss with this patient, we have the GLP-1 drugs discussion. So for this patient, the potential health benefits might be to improve diabetes control. So this person is already on 3 diabetes medications, diabetes not at target. We may have, this is really an effective drug to reduce, glycemia. And this person also had a heart attack and starting to have some complications, kidney complications of diabetes. So we have high quality data to show that it might reduce this person's risk of having another heart attack, stroke, and dying of cardiovascular disease, may also reduce the risk of kidney disease progression, and it may also lose some weight. Caution. So it may result in lean mass and muscle mass loss and also bone loss, especially if weight loss is large. And limited data suggests that fracture risk may be slightly elevated in this age group. So in this patient, there are several benefits. We'll discuss the strategies we may put in place to optimize the benefits while minimizing the risk. The second case scenario is quite different because this woman is younger. Um, she doesn't have diabetes, but she has already had like metabolic liver disease, had a heart attack, wants to improve her quality of life. So the potential health benefits for her would be weight loss, reduce the risk of having another heart attack, stroke, and dying of cardiovascular disease, reduce the risk of kidney disease, improve metabolic liver disease. And although there are some data, but the high quality studies are coming on that there may be improvement in the pain due to osteoarthritis. Caution, so it may result in lean mass loss, especially if weight loss is large. But for this patient, unfortunately, we have no data on bone outcomes so far. So now, after the discussion, they really want to know, what they can do to reduce their risk of losing muscle and bone. So here is what the ideal obesity medicine would be, and even diabetes medicine. So fat mass loss with muscle and bone preservation. So nutrition is really important. So we'll discuss that. Physical activity as well. And just to let you know that there are novel GLP-1 drugs in development that want to target in addition. So having in the same drug, so the GLP-1, dual GLP-1, GIP, perhaps with molecules that target muscle. So I wanted to present one study. I think this is the only one actually that I know of, a really good quality study that looked at what happens if we take a GLP-1 drug alone or we combine it with exercise in terms of weight loss, lean mass, and bone mass. So this was a study conducted in Denmark in people with obesity without diabetes, who were relatively young, a mean age of 43. And they did it a bit, I wanted to show you the design. Clinically, it's not how we would do it, but they did an 8-week low-calorie diet, so very low-calorie diet. And then randomized the people into 4 groups for a year. So people were randomized to either having the placebo, the GLP-1 drug that was studied in this instance was liraglutide at the dose of 3 milligram, which is the drug for weight loss, so higher dose for obesity. Then exercise, which was a quite intense program, so moderate to vigorous intensity exercise program, supervised with a kinesiologist, or a combination of liraglutide plus exercise. So what it showed, so you have the gray zone here, which is the weight loss period with the low-calorie diet. So all 4 groups lost on average a bit more than 12% of their initial weight. And then with the placebo in gray, there was some weight regain. With exercise, there was weight stabilization. That's something we know about exercise. It's really good for weight maintenance. With just the liraglutide in black, there was some extra weight loss, but then it stabilized. And interestingly, with the combination of liraglutide and exercise, there was an extra 4% weight loss during that year. So the combination is most effective for weight loss. But on top of that, it's even better for lean mass preservation. Actually, with exercise, there was an increase in lean mass in orange there, but with both the liraglutide and exercise, there was a lean mass preservation. But the difference was mainly with bone mass. So again, oh, I just wanted to say there, sorry. I go back to the lean mass story, but during the low calorie diet, you see there was like a almost 5% lean mass loss. So you can think that perhaps half of this was muscle mass loss out of 12% total weight loss. And then in terms of bone mass, at the hip and at the spine, which are the usual sites that we measure bone mass with a DEXA scan, bone density scan. So during the diet, low calorie diet, there was some amount of bone loss at the weight bearing site, like the hip. But then if you add liraglutide alone, you're gonna lose more bone. But if you combine with exercise, it's not different than having the placebo or exercise alone. In terms of at the spine, it's the same thing happening. So bone mass is stable with the combination versus bone loss with GLP-1 alone. So this is a really important study. I feel that we can mitigate these muscle wasting and bone loss with exercise. There's been no study looking at specifically nutrition plus exercise in this context, but there have been guidelines that I present here done on nutrient recommendations during weight loss, no matter what the cause is, but that's relevant for GLP-1 drugs. So we have what we call the bone supporting nutrients, which is protein. So protein intake is really important, especially in the context of GLP-1 use. When you have a reduced appetite, people have may have some nausea to start with. So there's a reduction in the total amount of food consumed, but it's really important to ensure that what you eat is high quality in terms of bone supporting nutrients. So protein intake in the general population, the recommended daily intake is 0.8 grams of protein per kilogram per day. So if you weigh 50 kilogram, it would be 0.8 times 50 kilograms. But in the context of weight loss, and especially if you're older, you already have a low muscle mass, malnutrition, and you're starting an exercise program, the recommended intake is higher than that. So it between 1.2 and 1.6 gram per kilogram per day. And it's important to have high quality protein at each meal and even during snacks throughout the day. It's better to have it separated during the day than just one large meal with protein. In terms of the other bone supporting nutrients such as calcium and vitamin D, it's the same as the general population. So it follows Health Canada and Osteoporosis Canada recommendations of vitamin D around 600 to 800 units a day, and calcium intake of 1000 to 1200 milligram per day. So if we start with calcium, so the message here is to try to get it from the food as much as possible. Why is that? Because the food is complex. You have other important nutrients in the food. And for example, dairy is a good source of calcium as well as of protein. But if it's not sufficient, then you should take calcium supplements as well. So the recommended, and another point I wanted to make here, a question I get quite often from my patients. So could you measure my calcium level in the blood to see if I get enough from the food? But it's not possible to do that. Why is that? Calcium in the blood is so important. It will be always normal, even though you have a really low calcium intake, because it's going to get it from your bones. So there's a really strong hormonal circuit that will get activated and you're gonna resorb your bone and end up having low bone mass. So depending on your age, on if you're a woman or man, so the intake varies as you can see here. So I've put here some examples of dietary sources of calcium. So for example, 1 cup of milk is equivalent to about 300 milligrams of calcium. It's not always not just cow's milk, even like a soy milk, almond milk, anything. It's most of the time enriched with calcium, the same as what's in cow's milk. And doesn't matter if it's a low-fat milk or high-fat milk, the same amount of calcium is there as well. And you have other sources. In terms of dietary sources of proteins, do you have? I found that on the net. It's really interesting. There are lots of resources on the net. I'm not a nutritionist, so but what does 20 grams of protein look like? So you have a list here, like for example, ground beef. 3 ounces of ground beef is 20 grams of protein. You have the low fat, the high fat, plant-based, animal-based. So everything is there to give you examples and of what you can do. And if you want to know if you're getting enough bone supporting nutrients, there's a really good resources at Osteoporosis Canada, a nutrient calculator available for free online. So you can just do the questionnaire here. And I've done it for myself, and it's what you're gonna get for all the bone supporting nutrients. You see, my intake was that. The recommended is that. So I'm failing that here. In terms of vitamin D intake, I'm failing again, so I'm not a really good person despite discussing this topic today. So I should take some supplements or increase my intake with the resources. Magnesium intake we haven't discussed today. Protein intake. Just to let you know that my intake here is based on 0.8 gram per kilogram per day. So as I said, it's more like 1.2, like if you're having your starting weight loss, and vitamin K intake here. So now let's move to exercise recommendations during weight loss. So here it's again like expert recommendation recently published. But what's important and what was part of the study as I presented as well was resistance training. So if you want to maintain muscle mass and bone mass, resistance training is a central component of these. So muscle with weights or elastic bands or anything. So at least 2 or 3 times a week, the large muscle groups, and it needs to be moderate to high intensity, but of course, starting lower and then progressing based on your fitness. Aerobic training as well, in addition to resistance training and not in place of, 3 to 5 times a week, 30 to 60-minute session. And if you have problems with your balance, you're at risk of falls, it's also good to include once or twice a week functional and balance exercise. I know it's a bit tough to kind of see that and know what to do exactly. There are resources for free, again, on the Osteoporosis Canada website. It's meant for people with osteoporosis, not necessarily for people like in the context of weight loss, but at least it's a start. So you have the QR code here, but it's all available online for free. So describing all the type of physical activities and examples of exercises you can do, easy to do at home without that many machines. And you can also order an exercise booklet called Too Fit to Fracture. You can download the PDF as well, and you have them also some exercises like in partnership with the University of Waterloo. My colleague here, Laura Gianni Gregorio, has developed interesting videos, podcasts on different things about exercise and bone health. But ideally, if you want to progress, I think it's good to have access to an exercise specialist as well. So here are the key messages of my presentation. So obesity is a risk factor for sarcopenia, so low bone mass, low muscle quality, and low bone quality. And the risk factors are having diabetes, older age, malnutrition, a sedentary lifestyle. GLP-1 drugs may lead to muscle and bone loss and increased fracture risk. The risk factors are a large weight loss, especially with the newer GLP-1 drugs for obesity. I've put a question mark without diabetes. The data are still very limited at the moment. Older age and people who are at a higher fracture risk to start with. But there may be a way to increase, to still have the benefits and limiting the effects on muscle and bone mass with nutrition, especially adequate protein, calcium, and vitamin D, and exercise. Main message incorporating resistance training in addition to and not in place of aerobic training may help mitigate bone and muscle loss during GLP-1 drug therapy. And novel therapies are under development. So with that, I'd like to thank you for your attention, and I'm ready for the questions. I'll stop share,
Thank
Tracie.
you, Dr. Gagnon. We did get so many questions, and that was so informative. Um, the question I'm getting a lot is what is defined as large weight loss? Um, Even on the Osteoporosis Canada website, when you look at risks for osteoporosis, we speak about significant weight loss. What does that mean? What does that look like?
Hmm. That's an interesting question. There's no like clear cutoff that I can say that is something you should worry about. That's a continuum, and it depends on where you start with in terms of bone health and muscle health. But generally speaking, we know that a 5% weight loss, you have a lot of the cardiovascular benefits and benefits on diabetes control as well, with 5% weight loss. And perhaps at that level, there's not much, there's not a large impact on bone and muscle loss. But when you go beyond that, perhaps more over 10% weight loss, it's what I would call probably a large weight loss. But it's a continuum.
Okay, that's great. And somebody actually just asked if you do have osteoporosis or if you're have low bone mass and you're not yet at osteoporosis, should you go for a BMD first before getting on a GLP-1?
Hmm. That's a good question. So if you already have risk factors that you presumably don't have a normal bone mass to start with, and you may lose bone mass during the treatment, I think that might be a good idea to have like a BMD testing before that, and then follow that over time. Depending on where you are, there are, I know that, I know more in Quebec here in the province of Quebec, but there might be, criteria for having a BMD. So it's just a question of like seeing if it can be reimbursed by the provincial government. But that might be good to know where you start. Yeah.
Okay, wonderful. Oh, the questions keep coming. So this individual is wanting to know, do GLP medications like Ozempic interfere with an osteoporosis medication like Resendronate?
That's a really good question. So first of all, it doesn't interfere. So in terms of like just purely pharmacology, there's absolutely no impairment of how GLP-1 drugs work or osteoporosis medications work when they're combined. Like they work fine. Both drugs will work fine. Um, the question is more, if you're already taking like Risedronate or any osteoporosis medication, it means that you have osteoporosis to start with. So you might be at higher risk, with starting a GLP-1 of losing bone, despite being on an osteoporosis medication. Actually, we don't have data to show like what happens, with you. But we know if I extrapolate to bariatric surgery, so there have been data showing that if you give bisphosphonate or denosumab before having like the bariatric surgery, and of course they're gonna lose a lot of weight after that. So it's the same thing, but a larger weight loss. You actually block bone loss that happens. So I would think that these medications, like anti-osteoporosis drugs, should work fine while you're even losing weight. But it would be even better if you do resistance training, exercise, and you ensure you have enough bone supporting nutrients.
Perfect. Now, kind of along that same line of questioning, someone is wanting to know about menopause hormone therapy. So,
Mhm.
is there any concern if they're on MHT and also taking the GLP-1? I see you shaking your head. So,
Not that I know of.
okay,
I haven't
yeah.
reviewed like extensively, to
Mhm.
be honest, like this literature, like the combination, but I wouldn't think that there would be a concern, honestly. And hormone replacement therapy, we know it's a good treatment for osteoporosis prevention. So it works in a similar way, if you want, as a bisphosphonate. So I think it would actually, perhaps, I would hypothesize, help actually minimizing the bone loss while starting the GLP-1. But we don't have data on that. But I don't see a problem really.
Okay. And another common question we're getting is once you start taking a GLP-1, regardless of which one it is, if you take it for an extended period of time and then you stop,
Mm,
are all the results that you've achieved in terms of,
mm.
if you're diabetic or, if you've lost all this weight, is it going to all revert back? Do you have to stay on GLP-1s forever once you start?
That's a really good question. And actually, there's just a study that came out, a large study about exactly that question. So that's a really relevant question, and that we get a lot in the clinic as well. Uh, so first of all, if you want to have, still have the benefits of the drug, you have to continue it. So this study showed that if you stop, you're going to have weight regain, especially if there wasn't any like lifestyle changes around that, like exercise, nutrition. And the benefits on cardiovascular health, kidney health, and everything will also disappear. And this study showed, like looking at markers of cardiovascular outcomes, like about a year and a half after stopping the medication. I explain it to my patients that, we have to view when you start these drugs, I mean, I've noticed that some of my patients feel kind of guilty of starting these drugs because they they explained to me that they feel that they failed in a sense, like the lifestyle changes, they do that and do this, and it doesn't work. And I explained to them, it's a health condition. So that's a chronic disease. So it's like, for me, it's like hypertension, it's like high cholesterol, it's like diabetes. Um, so when we start a medication for these conditions, we think we're going to continue it for a long time, because if you stop it, hypertension will come back. So it's the same with these medications. They don't have a lasting effect. Um, so I don't know if it answers the question.
Yes, and thank you for also mentioning about how people feel about this, because is it a barrier for people who
Mhm.
feel like there is some judgment around people? We've heard it, it's in the media, and it's out there around people who choose to take these medications. And so we don't want to have barriers to people being able to get the medical support that they need for all conditions. So that's great. Thank you for speaking to that. Um, we do have time for a couple more questions because we've
That's
received
good.
so many. This is great. So um, there's another question about the rate of weight loss. So if somebody is on a GLP-1 and is really losing weight at a very fast rate of time,
Mhm.
does that have an effect on bone loss?
That's another really great
We're
question.
knocking them out of the park today.
Yeah, I have to do again a parallel with bariatric surgery, perhaps, because I don't think we have like strong data about that. A study that looked at specifically what happens if you lose weight slowly or if you lose it really rapidly. My own opinion is that I think that if you lose it really more rapidly, and I do get a parallel with menopause and everything. The first few years of menopause, we know that's the zone of bone fragility, because your skeleton doesn't have time kind of to adapt to that. And you're in a period of like more fragility, especially with you start with already some kind of compromised bone health, you're older, you're entering menopause transition and everything. So you have another factor increasing bone loss. So I guess if we could do it perhaps a bit more slowly and making sure I repeat it, but that's so important, bone supporting nutrients and exercise. And I know at least in Quebec, in our healthcare system, that's sad, but we don't have access to exercise specialists for free, which is a problem, I think. But just keep in mind that when you start these medications, I think it's probably true in the other provinces as well. Some of these companies, pharmaceutical companies, have patient programs where you can have access for free when you start these medications to a nutritionist, and I believe also to exercise specialists for some sessions.
Okay.
So perhaps make sure you take this opportunity if you have access to it.
Yes. And the last question, unfortunately, we only have time for one more question, but is there a risk of individuals being malnourished because the appetite is now really reduced, and it's you need to be so diligent as you were speaking to about the nutrition, but there is a risk, especially if your appetite has shrunken and you're limiting the amount of foods. What can you reinforce to that about what food people eat and when?
Ag- Again, so good a question, actually. Um, I think the thing is, it's important to make sure you get hydration enough. It's not related to bone health, but just people get nausea, sometimes vomiting, and you don't have to have like acute, like kidney disease because you've been dehydrated. So very important to keep hydrated. Having said that, it's true, your appetite is really reduced. So one strategy is to have smaller meals or even smaller snacks, such as multiple snacks during the day, instead of having like these big meals. And make sure that what you have in it is you prioritize the protein and calcium. And vitamin D you can have through the pills, and it's mostly in the pills anyway. But protein and calcium is really, really important. Actually, it's really interesting because we're gonna have we want to start a research project on looking at the what happens to the type of food that people have, and what happens if you have a higher, protein intake and everything while starting a GLP-1. So what does it do to the bone markers and muscle mass? So we might have the answers to these questions, but these are general recommendations that I believe apply perfectly to the GLP-1 situation.
Dr. Gagnon, thank you so much. We thank everyone for joining us.
A
I
pleasure.
do have to wrap up right now. And so I'm just here on the deck, which is apologies. It's just taking a pause here. Thank you to everyone who has joined us. Sorry, it is. There we go. Sorry about that. All right, so we do have tools to help. I encourage you to get on the Osteoporosis Canada website, download or use a nutrient calculator. You can go to it works on smartphones. So whether you need to go to the Apple Store or Google, you can download the app. You can track what you are eating. You can learn about other foods that have protein, calcium, some foods that have vitamin D, vitamin K, and magnesium. Also, this is being recorded, so you can watch this again. Those that have registered, you'll receive the email probably by tomorrow, and it will be on the OC Replay webpage, just like other content, like the Menopause and Bone Health webinar. And we have recipes. So there are recipes on the website that are developed to include the bone building nutrients that we discussed. And of course, we have the podcast on the OC website, but also on your favorite podcast provider like iTunes, etc., YouTube Music. So please visit the website. Thank you to Dr. Claudia Gagnon again. This was wonderful, so informative, so much information. Also to our partner ThinkBeef.ca, who helps us, partnering, getting programs like this up for everyone. Coming up, they're still not on the website. We're working on it. There will be a webinar on emergency preparedness in July. Of course, a summer cooking demo as well in July, and a webinar on breast cancer and bone health in September. Check your email, check the website in the coming weeks so you can register and join us. And of course, osteoporosis.ca, lots of information. We're on social, Instagram, Facebook, YouTube, and LinkedIn. Thank you to everyone. Have a wonderful rest of your day until we see you again. Take care. Bye bye.
Thank you.